Hi, everyone. It's Dr. Sheftal again with Truth in Science. Dr. Bhattacharya and I just took a little bit of a break, and we're going to go ahead and start part 5 right in after part 4. So we're back, ready to go. You ready, Jay?
I'm ready.
Fantastic. Okay, let's do it. Boy, I'll tell you, the first slide is a doozy. I can't ever get it to work with the buttons. Okay, did your thing change, Jay?
Yep.
Okay. And we'll skip this one again. Now, what do you think of the picture I selected this time? Very nice. Huh?
Nice.
I love this picture. This is a major picture in the history of this disease, I think. This is presumably in the city of Great Barrington, Massachusetts, is it?
It is, yeah. It's where on the left is Martin Kulldorff, who was then a professor at biostatistics at Harvard, a fantastic epidemiologist. Sunetra Gupta is in the middle from Oxford University. She is probably the world's best epidemiologist, in my view. And then me on the right.
And I'm sure you're very happy and honored in a way, because these are your colleagues, and you guys created the document that was heard all around the world, which is a great.
I'll tell you a funny story. When I saw this picture, someone was looking at it going, "This looks like a rock star video." You know, like I should have like a guitar, like a bass. Sunetra needs to have a microphone, and Mark needs to have a guitar.
Yeah.
Electric guitar.
Now, can you tell us a little bit about the history? The building behind is what?
So we went to this institute called the American AIER, American Institute for Economic Research, that hosted this little conference. Martin organized it, basically. Martin, he wasn't part of AIER, he just got an invitation from them to organize a conference. He invited Sunetra from Oxford and me from Stanford in October of 2020. And it was like a little bit of a complication to help get Sunetra permission to come into the US. And when we arrived, we basically—
Because of COVID, had they blocked flights from— she's from Great Britain, I assume.
Yeah, so back then it was really restricted, the number of flights allowed. And so when we arrived, we didn't have a plan to write a document. Actually, we had a plan to discuss our views about, just kind of like we're doing, Reed. Discuss our views about the science and COVID and the policy. And we realized that we needed to write something. Like, we'd kind of arrived at the same place from different directions. As far as the policy, so the document came out of that discussion after Sunetra arrived. Martin and I arrived first, and the Sunetra later that evening. And then we told some folks at AIER about it, and they got all excited. They were like, okay, maybe we could put a website together and maybe get into a petition. And that's what happened. So we put it up. It went viral. There was a website where you could just sign your name, and 1 million people signed it almost now. I think it was like 800,000, tens of thousands of doctors, 15,000 scientists and epidemiologists signed it. And then it sort of, the world kind of exploded around it for me personally. I mean,
it was an amazing document. I signed it.
Oh, thank you, Reed.
Yeah, absolutely. I think was it released in early October?
October 4th. 4 days later, after we signed it and it released it and went viral, there was an email from Francis Collins, who's the head of the NIH, to Tony Fauci, calling the three of us fringe epidemiologists, and then asking Fauci to deliver a devastating published takedown of the premises. Yeah. To which Fauci responded with a Wired magazine article.
Yeah, one of the great scientific journals of all time, right?
I mean, and then reporters start rolling their eyes. I mean, it's remarkable, actually. What happened with us is, I think, how a lot of the establishment has dealt with criticism. Rather than actually dealing with criticism, they've sought to destroy the reputations of and marginalize people who disagreed with them. Right. This has happened with the lockdowns, of course, and the Great Barrington Declaration, but also with the lab origins of the disease, and also with the possibility of early treatment, natural immunity. I mean, I think what's happened over and over again is the people like Tony Fauci, who have this responsibility to engage with the scientific community, instead has dictated the scientific community. And he's used the press and big tech to suppress points of view that he didn't agree with. That's what you face too, Reed.
Oh yeah, terrible. Now, here's the thing about it though. All of those people are fighting such a horrible losing battle. I mean, you know, to go for the political way of winning an argument, basically by going to all these popular magazines and trying to besmirch someone. That's not what science should be, is, ever will be, or anything. And that's what amazes me about it. I mean, if they'd have said, look, let's put together a counter argument and try to get it published in the Lancet or something like that, that would have been okay, really.
But no, they did actually. So eventually, later that month, a group of them, although Tony Fauci didn't sign, but like the current CDC director did sign. She wasn't CDC director then. Right. Called something called the John Snow Memorandum. Okay. John Snow, who's like the very famous epidemiologist who solved cholera, the mystery of cholera in like I think 18th century London or 19. Anyways.
Oh wow! He's no longer with us.
No, yeah. Well, he's a very famous epidemiologist because he identified the water source, the Broad Street pump, where cholera was sort of coming out. I mean, he did this like detailed survey, a map of London, and found all of the cases of cholera were like clustered around this one pump where water was pumped out, and said, "Well, shut the pump down, the cholera epidemic will go away," and it worked.
Yeah,
he was actually incredibly controversial at the time. The Lancet attacked him. The prevailing theory was this miasma theory. Bad air was causing cholera. Yeah. And there was huge like public works projects to like, relieve sewage and all this. Like, oh no, cholera is this multifaceted problem. Turns out it was just this focus protection thing. You just need to like shut down this pump where the bad water was coming out of. Mm-hmm. So they wrote this counter thing called the John Snow Memorandum in late October, published in the Lancet, premised on the idea that there's no natural immunity.
That there's no natural immunity. Oh my!
There's no immunity after COVID recovery. That was the premise of the thing.
But that makes. Sorry.
That makes no sense. But that's exactly what the CDC director, a very large number of prominent scientists signed it. Although not as many as the.
Dr. Redfield was the CDC director at the time. I think.
He was, but I think no government official was allowed to sign it. But there were a lot of like. COVID Twitter scientists that signed it for sure. Yeah. And it wasn't as, I mean, the thing is interesting is like, it wasn't as popular because it's premised on a falsehood, right? There is actually, immunity after COVID recovery. And so then they use that to like attack us. I mean, it was really something else.
Yeah. But it's comical though, when someone uses a premise that anyone that knows anything knows is false to attack you. It just puts no weight behind the argument. For example, you mentioned a study after I presented my proof of the lab leak hypothesis. Remember that?
Yeah.
From somebody, I don't know whether, for some reason, Arizona and Australia come to mind, but he was from somewhere and he said that he had definitely proved that the virus started in the wet market because they found some fingerprints, if you will, on some of the metal bars or something. And of course, that doesn't prove anything. So his refutation of someone like me has no weight at all. You know what I'm talking about? That paper.
Yeah, I mean, like basically what they showed there was that, okay, yeah, so there was some SARS-CoV-2 in some animal cages or something.
Right. But they haven't found an animal, and anybody could have put it there at any time.
But yeah, that's the point. Is like this disease spreads among mammals. The fact that you found some of the SARS-CoV-2, I mean, virus there does not mean that that's the origin of it. It just means that it was found there.
But I'll tell you, the way I heard about it was I listened to an interview of the guy that wrote the paper. And the interviewer and he were talking that it was just eureka. We finally figured it out. And I'm thinking, what is going on here? This doesn't prove anything. And the New York Times
wrote a
even
massive
put an
story.
article about it. And
The
it
New York
shows
Times
you
wrote a story.
it kind of shows you the bias of the New York Times. That the logic behind that thing wouldn't have passed muster by anyone that's a thinking person, and yet the New York Times put it out there, and the New York Times has failed to cover a lot of stories that are sort of the other narrative, if you will. They won't publish that, but they'll publish this shoddy reasoning paper. You know, it just it's weird. Journalism has really gotten strange. There's a lot of corporate influence on journalism, it seems like to me.
Yeah.
But are you ready to go?
Yeah, let's go.
Great. Okay, we stopped here, so let's start here again and see where we are.
Sure.
The point I was trying to make about it being, it makes sense that it could be an ethical decision, but when you're talking about vaccinating the controls in the children, when you only had, and I'll show all the exact numbers in a minute, but it was about 1,500 in the vaccinated group and 750 in the control group, which is way too small of a number. And of course, nobody had any problems from it, because that's way too small of a cohort for the complications and the disease to express itself in. Nobody got anything, of course.
So, I mean, like, it's actually fairly common for vaccines and drugs, when they're approved, to not really know the full safety profile. And it's always for the same reason. It's the reason you just said, Reed. It's you never have a trial big enough to find.
Right. You're going to have some surprises for sure, right?
Right. So what happens is you have a infrastructure inside the FDA and to actually track post-market after post-market approval what the safety profile is, using essentially cohort studies, like a massive cohort. And the way that this works, and I know this because I actually work with the FDA on this system that's called the BEST system, for BEST, for biologics effectiveness surveillance tracking or something like that. It's a system where you use healthcare claims data. Healthcare claims data are actually quite good for this kind of thing, because, okay, so you have, let's just take Medicare. Medicare is the insurance coverage for the elderly in the United States.
Oh, I see. Claims by the doctors, yeah. Yeah,
so every time a Medicare patient goes and sees a doctor, is admitted to a hospital, or gets a drug, that generates a claim to the federal government sees, so they pay it out. On that claim is all kinds of detailed information about the patient, including the diagnosis that led to that the visit was about, procedures that were done, all kinds of things, and you have them tracked for each patient across all until the patient dies, from the time they enter Medicare to the time that they die.
Yeah.
So you can with this, and then you have vaccination records. You link it to vaccination records. You know when they're vaccinated. You can track patients who are vaccinated, compare them to a control group who were not vaccinated, and tracked over time. And with statistical methods, you can look to see if there's a signal of heart attacks, cancer, things like that, that are higher in the vaccinated group than the unvaccinated group, or the higher in the group that got the drugs versus didn't get the drugs, or whatever. That's the kind of system that are used. Yep.
The question I have about that, though, is, I mean, there is some science that goes into controlling for confounding variables when you do a study. But when you do is it chart review that does that? I mean, are they literally? Yeah.
So let me.
How would they keep the confounding variables out of something like that?
Yeah. So you have to. So it's what I just described as the broad overview of it. There's a lot of detail and important detail that goes into addressing exactly that point about confounding variables. It's not perfect. It's not a randomized trial. But it tries as hard as it can, because you can't, these are post-market. And there's a principle here, like, the randomized trial is tested in certain populations. often the drug or product or vaccine is used outside of those populations, and you're going to see things you didn't expect.
Yes.
Right. So, but the advantage of this system, it's harder to do to address the confounding, although there are methods to try to address the confounding. But the big advantage is you have broad populations being used on, so you can observe what's happening in broad populations, and you have massive sample sizes. The entire Medicare population, for instance.
That's a huge help, I would think.
Yeah,
But
I mean, so there's trade-offs.
You don't have the blind aspect of it. Well, you don't have the blind aspect.
It's not controlled. It's not randomized.
Yeah.
So you don't have that aspect of it, which is important.
Mm-hmm.
But there, as I said, there are statistical methods to try to address that. Like the methods, for instance, as using, sometimes in drugs, you can use people who are not on a drug, and then they start on a drug, and then you observe them afterwards, and you observe if the drug has short-term side effects. You can use them as themselves as a control, right? So it's called a self-control study.
Mm-hmm.
There are other things where, like, maybe the product is rolled out in one part of the country before it's rolled out in another. So you can look in one part. I mean, there are ways to try to address it in the observational data. It's never going to be perfect. It's not going to be like the randomized studies.
The thing that would bother me about it, just hearing, I've never heard of this before, but just hearing it straight up would be that if you want to try to control for things by looking at the charts in detail, you're going to see who was vaccinated and who wasn't, and that might influence how you group them out. Also.
Yeah, it's not blind. It can't be blinded.
Yeah,
but it's retrospective. But so there are definitely limitations. But this is how basically the safety of every drug and every product is tracked. Now, usually the statistical systems, what they'll do is they'll raise a signal. Okay, so for instance, that's what happened with the myocarditis in children.
Right.
There's another system called the VSD system inside the CDC and FDA.
What is VAERS? How does VAERS relate to that? Is that
so? VAERS is the third system that's commonly used.
Okay.
There's three major ones. A new one called vSafe, which is more like VAERS. So the two that are most reliable are BEST and VSD. VSD is Vaccine Safety Data Link. Neither are really visible to the public.
Oh.
It's basically researchers inside the FDA and the CDC that work on it. And then they have the contractors like me sometimes will work on it. But then there's then the VAERS system that's openly visible. But the problem with the VAERS system, unlike the VSD system and the BEST system, which have control groups that you can build, at least in principle, and try to address the confounding.
Right.
VAERS is just every time a doctor sees a side effect after a vaccination event or some event, people or the pharmaceutical company hears about it, or public health, they'll report it to VAERS. But there's no control group. There's no baseline. How many heart attacks would you expect? How many myocarditis events would you expect in this group? That's why you have to have that unvaccinated control. And that's why this loss of control. So I assume you put this slide up. Right? That control group is quite important to understand.
Yeah. So that's a point in my favor, though, of being a little skeptical, because once you wreck the control group in a more precise study, you always have the excuse that
it just means that you can't use the trial data to look at long-term outcomes. But you should we have used these other systems to try to track outcomes. And as I said, there's trade-offs, right? So you lose exactly what you said. You lose the fact that it's randomized, which is very bad. But at the same time, you also gain the large number of people in the study, and you also gain the fact that populations that weren't in the trial, you can study them.
Right. That's a good point, because I understand I'll get to it, but pregnant
trial, they didn't have any children. They have no children in the original trial.
Right.
Very few children have been put in trials at all. The endpoints for children in the trials have been, antibody development rather than prevention of severe disease.
I've got all those numbers as we move through these slides, and they're important as hell, of course, because we'll let you explain that about the statistical significance of having a trial with 750 children in the control and 1,500 in the treated. That's too low.
Yeah, so
the incidence of the disease and everything. It just,
I mean, I think the issue here is that so people have looked at VAERS, and there's a lot of reports in VAERS about side effects.
yeah.
But really, you do need a system that has the control group built in, so you have some understanding of how many you would expect.
Right.
And those systems, that's how we learned about myocarditis in kids, for instance.
Yeah.
It's those systems, like the VSD system showed that. There was a signal in the BEST system on heart attacks in older people. Now, usually that's followed up with chart review, like careful chart review to try to say,
make sure that diagnoses weren't incorrectly entered. And with
so
VAERS, correct me if I'm wrong, but can't the public send stuff into VAERS?
Yeah, anyone can.
So they could be anti something or in favor of something, and not that they would make something up, but
well, you're just sensitive to it. Like this is
different motivations. Yeah, there some people, certain people would be more sensitive to certain things than others, and that'll throw it off, right?
Yeah. So the VAERS is very useful for generating hypotheses, right? Yeah. So you see the myocarditis numbers pop up in VAERS.
Yeah.
That's what caused the VSD folks to look at myocarditis in children, because they were like, okay, well, we're seeing this big spike. Myocarditis very rarely happens in children. Why are we seeing myocarditis after the vaccines?
Yeah.
It shouldn't happen unless it's a side effect. And then they did a careful study they use electronic health records rather than claims. The VSD system does, and that's how they found that myocarditis, that the vaccine causes myocarditis.
Yeah. Okay. Let me go ahead now, because I've got all the bar graphs for that, which are incredibly interesting. So you want to go ahead? I mean,
yeah, please.
And get to some of the. So now I probably wrote this title when I was in a bad mood, but it's a little harsh. But I'll tell you something, there were some weird things that went on during this trial, at least what I read. And one of them was that they used luciferase to see where the nanoparticle went, because luciferase, for the viewers.
That's not in was it in a human study or in like some
I think it was in a model. I think.
Yeah, because I don't think it's not in the.
I think so, but I'm not sure. But anyway, it's an enzyme that has a biofluorescence marker on it, correct? And so it lights up. And they took the photograph of the whole body, and it was lighting up everywhere, even though they injected it.
Yeah, I mean, I think I forget what mammal. I think it was like it was some kind of monkey study, I think, or okay. I can't remember.
Well, what was interesting about this is I found this issue after it just came into my head before the vaccines were released. And I don't know anything about vaccinology or anything, but I'm thinking to myself, what if when they injected into the deltoid, while I'm making a video, and I just thought out loud, I said, when they injected into the deltoid, it gets into the circulatory system and goes to other organs. I said, I don't mind if I lose a few deltoid cells because of the major histocompatibility class 1 cascade we've talked about, but I don't want to go into my heart or my brain or something. And it turns out it does do that a little bit. There was a Canadian, I think he's a veterinarian, but I'm not sure, Dr. Bridle, that found a report from Japan where they had done some study on whether it was going to other organs. But I'll show you that I actually made a picture of it in this presentation that you and I are going to discuss. So we can discuss it when we get to that. But the other thing that bothered me about this, other than not investigating light emitting from everywhere, was that animal trials, which are normally a major part of a vaccine release, for sure, right, weren't conducted this time. They were rushing this, and they didn't do the animal trials that they had done on SARS-1, where I talked about that it very probably was antibody-dependent enhancement that killed the ferrets that got the vaccine more than the placebo group died when they all got exposed to the wild-type virus. So they didn't do animal trials this time, right? Before they did.
I think they did some animal studies. I actually don't know the full extent of this. So
okay.
My sense, I don't know that they didn't do any. I'm not sure, actually. I'm not sure.
Well, I just think that the human trials were started pretty much as soon as they could start.
Yeah, so that's the things, like, what if this was the vaccine candidate they had available almost immediately afterwards? The thing I don't have any visibility on is what studies they did before the disease, before to lead them to this vaccine candidate. They must have had something that thought
they did a lot of stuff in the bat caves in Yunnan. If you read that DARPA thing, it'll blow your mind. They were doing some reckless stuff in my eyes. I mean, they were injecting bats with these juiced up spike proteins, that they had reverse engineered from mouse, humanized mice, which of course is a mouse with cells in it that have human ACE2 receptors on it, not mouse ACE2 receptors. Because they wanted to find out if this thing could get into humans. And the bats were flying free in the cave, I think. Yeah. And they would inoculate some of them with spike proteins and see if they mounted an antibody response to it. I mean, it was amazing. Yeah. So now here's something that really is important. It took me a long time to find this because I got conflicting answers on this incredibly important issue. And that is, how many people died in the trial? And, Robert Kennedy Jr. Makes a lot of speeches and stuff. And he had said that in one of his speeches that 20 people died in the vaccinated group and 14 in the control group. And then I heard another speaker say that 15 died in the vaccinated group and 14 in the control group. And there's quite a difference there. So I looked it up and I actually found it. If you look, this is real hard to read because it's so small on this screen and the viewers may not be able to read it, but I'll read it to you. It says, from dose 1 through the March 13th, 2021 data cutoff date, I guess that's when they stopped collecting, there were a total of 38 deaths, 21 in the co-morbidities group. And the co-morbidities group, of course, is the Pfizer BioNTech group, and 17 in the placebo group. So this is literally from the horse's mouth here. I got this from the Pfizer data release recently. And so it was 21 and 17 is the actual numbers for a total of 38 deaths. But I'll tell you, 21 deaths in the treated group and 17 in the placebo group bothers me.
So let me just say, so that those are small numbers. Yes. Out of tens of thousands or whatever people in the trial.
They had 18,000 some odd. I'll show you all that in a minute.
So the thing is, that is not a statistically significant difference.
21 down to 17 is not enough.
No. Okay. So what you can say is that there's no statistically significant evidence that there's any all-cause mortality benefit from vaccination. That you can say with certainty. Right. I don't know that the vaccine kills you. I also don't know the vaccine saves you. And this is all cause death, not just COVID death.
Yes, it's all cause for sure. Yeah.
There's a really interesting study out of Denmark that just came out a few days ago by this group led by Christine Stable-Ben that found the same result. Okay. That the vaccinated and unvaccinated died at about the same rate. There was no statistically significant difference in the vaccinated. Now, she found that for the mRNA vaccines. For the adenovirus vaccines, actually, she found an all-cause death benefit.
The adenovirus vaccines benefited?
Yes, they're actually reductions in all-cause death relative to the unvaccinated in the adenovirus vaccine, but no difference between in all-cause deaths between the people who got the mRNA vaccines and people who didn't get any vaccines.
Now the adeno, just for the viewers, that's a recombinant vaccine, right?
Yeah, so it's actually similar technology, right? So it's in one sense. Yeah. I mean, except the delivery device is not a nanoparticle. It's essentially an adenovirus, like deactivated adenovirus, and they add the mRNA sequence that they know will get expressed to put the spike protein in. I think it's the same spike protein actually.
Oh, sure, yeah. I mean, I think it's almost the same thing, really. The final result. I mean, it's getting by recombination, it's getting the little piece of the genome that codes for the spike protein into the cell, the human cell, and to make the spike protein.
But it's really interesting, right? So that in this epidemiological study by Stable Ben and so on, out of Denmark, it essentially replicates the trial numbers, right? No difference in all-cause death. And actually, her group also found that there was a reduction in COVID mortality by the mRNA vaccines. So you see a reductions in COVID mortality, no change in all-cause death. This is actually pretty close to the study. Now, it's not quite the study because the randomized study doesn't look at all-cause death. That doesn't look at COVID deaths. That's not the outcome.
All-cause, yeah, sure.
No, it's looking at it's only looking at symptomatic COVID disease. It's not looking at mortality or hospitalizations as an endpoint.
Right. Yeah. Oh, it's using the same primary efficacy endpoint as the Pfizer trial used.
Okay, so I'm not being clear.
Wait, I'm sorry.
The Stable Ben study, the Denmark study, found a reduction in COVID-related deaths.
Yes.
From the COVID vaccine, from the mRNA vaccines.
Okay.
But no difference in all-cause excess deaths.
Right.
The randomized trial, the Pfizer trial, found no difference in all-cause excess death, just like the Stable Ben result, but a reduction in symptomatic disease.
Right.
But it didn't actually report hospitalizations from COVID.
Okay.
At least I don't remember seeing it.
So that would have been a secondary, whatever it's called. I mean,
it should have been the primary endpoint. Like the purpose of the vaccines, I think, is to prevent severe disease and death for, especially the elderly, for whom the disease is deadly. Yeah. So that should have been the primary endpoint. Instead, they chose the prevention of symptomatic disease as the endpoint.
Yeah, right. Yeah. Yeah, it was weird. The primary efficacy endpoint, which we'll get to in a second, is a little odd, but I'll show it to you then. Now, the public has fared much worse than the trial participants from the Pfizer BioNTech trial.
Right. So I guess I would say, if that Stable Ben, that Danish study is right, it's not that they fared worse. They fared exactly how you would have expected, given there's no difference in the trial between in all-cause death, between no statistically significant difference in the trial between in all-cause excess deaths between the vaccinated and the control arms.
But I think in the data that I've heard, because have you heard about these life insurance guys coming on TV and saying, listen, there was a 40% increase in the third and fourth quarters of 2021 in our actuarial studies, and a 3 sigma event happens every 200 years, okay? And that's only a 10% increase. So a 40% increase is so gargantuan that they almost can't believe it happened. And it happened in the third and fourth quarters of 2021.
Yeah, so there's lots of...
That's what I mean about the real world. And, there's a lot of reasons for it. Certainly the lockdowns is part of it.
Yeah, exactly. Lockdowns. I mean, I think teasing apart exactly the cause of that. So for instance, it's different in younger people versus older people. Again,
sure.
You're seeing this excess deaths in younger people. That could be extended. Lockdown harms take a while to manifest.
Yeah, I mean, some of them happen pretty fast, though, too. I mean, there's
some of them do. Well, it was like this. Like in 2021, there was the number of deaths from alcoholism and from drug overdoses in the United States skyrocketed.
Yeah, absolutely.
Especially in younger people. So I think it'll be a while before we fully understand what caused that, but. I'll just say, like, the vaccines did not stop this death from happening. And if you look in the trial data, as you're showing us,
there's not. Yeah.
We shouldn't have expected it to.
Pardon me?
We shouldn't have expected it to, right? There's no difference.
To reduce the all-cause mortality?
Yeah, because the all-cause mortality in the trial is no different, right? That's what you just told me, and that's true. 21 versus 17.
Well, yeah. I mean, I know that you're right because you know what you're talking about. I would have thought someone had just asked me on the street, is there a significant difference when you've got one group having 20 deaths and the other group 17, I might have thought, well, let's see, does it depend on the number of people in the study and things like that? But I'll tell you, that is a 4/17, which is a little bit less than a 25% increase in deaths. I'm surprised that's not.
Yeah, but it's the problem is the sample size is not big enough.
It's too small, right?
I mean, if they wanted to distinguish all-cause excess death or death from COVID,
Yeah,
they needed to run a much larger trial.
yes, correct. Yeah. But
So
let me ask you about that in particular. Do they cherry pick the participants in trials? Because if you get a lot of really healthy people, you're certainly going to, even if you have a little bit of a dangerous vaccine, they're not going to die at the rate of the general public.
I mean, generally, that what they'll have like a pre-registered set of inclusion criteria.
Exclusion criteria. Okay.
Exclusion and inclusion criteria, right? So they'll try to they'll tell the people who are recruiting patients to make sure that they meet those exclusion and inclusion criteria. The mystery to me about this trial was that it was so clear that the strongest use case for the vaccine would be older people. They under-enrolled older people.
Yeah, they did. Yeah, I've got that in my slide here. The elderly were underrepresented in this trial, and that's
I don't think they cherry picked, and I think what happened was that they thought the vaccine would stop disease transmission, in which case, really, you need to check against, does it stop transmission in young people? They weren't thinking about the vaccine as a way to do focused protection. In that case, the key group is older people.
Yes.
So I think that they just misunderstood the correct epidemiological use of the vaccine.
Yeah. Yes. I got in an argument with this guy I don't even know, but he played the junior tennis circuit in Florida when I was a junior, and he's a doctor now. He's a research doctor. And I said, listen, why aren't they, how could they get away with not having a lot of elderly people in the trial? That's the group that you really need to know more about.
Yeah.
And he seemed to say, oh, it doesn't matter or something, I don't know. And then I thought, well, he's a researcher. He should know how to conduct a trial or what it means or something. And I didn't pursue it, but never made sense to me that they were underrepresented in the group that
doesn't make sense.
Benefit the most from it.
You're correct.
Yeah.
100% correct. That should have been the group that was tracked, or that was like prioritized for the trial, because that's the group that's most at risk. So like, if you think about the vaccine, there's two real ways that we could have used the vaccine.
Yeah.
And I think the problem was that the people that manufactured the vaccine and the policymakers that implemented the policies we've had picked the wrong one.
Yeah.
Right? We could have used the vaccine for focused protection of the elderly and other people at risk. Right? That would have meant a trial with many elderly people, mostly elderly people recruited, other high-risk people with an endpoint of severe disease.
Yes.
And you wouldn't even need a huge trial there, because it's actually quite common. The outcome is quite common: death and
right. Yeah. Exactly. You'd have a lot of the placebo group reaching the endpoint, but in the real trials, you had 162 people reaching it out of 18,000 and.
Yeah, so that's the thing. So that's one way you could have thought about the trial, in which case you would have designed it very differently.
Yeah.
The other way you can think about the trial is, well, this is a way to get rid of this. This is how you get to herd immunity. You get a vaccine that sterilizes, and that then people don't pass the disease on to anyone else.
Correct.
And that solves the problem. That solves the epidemic.
Right.
That's the trial they tried to that's the trial they were aiming at.
Because they were assuming that it would block transmission.
Not assuming, they wanted to check. Look, okay, there's two different uses for the vaccine, depending on the properties of the vaccine. Which put yourself back in like July of 2020 or whatever, June of 2020 or April of 2020, when they're designing the trial. There's two possible uses for the vaccine. I don't know which one's going to work. It depends on the properties of the vaccine, which I don't yet know because I haven't run the trial. I can either aim at a vaccine that protects against severe disease and death,
right,
and the group that's vulnerable to it, or I can aim at a vaccine that stops transmission.
Yes.
I think they decided against a vaccine that stops just severe disease and death.
And then they
Otherwise,
use
they
as
would
the
have.
primary efficacy endpoint symptoms.
That's why they use symptoms. So so they chose the other path. They use this path of let's look at the vaccine's ability to stop disease transmission, but they didn't actually have that as an endpoint. Instead, they had symptomatic infection as an endpoint.
So isn't that weird? That sounds really weird to me.
So it is weird, actually. It's weird. They should have, so they were like stuck in the middle. They have a trial that neither checked to see if it could stop severe disease and death, nor whether it could stop could stop disease transmission. Those would be the true primary epidemiological purposes of the vaccine.
Right.
Instead, they picked an endpoint that's neither here nor there.
Yeah. I mean, when you read that thing, I mean, when I read it, I'm thinking, I mean, you got to stick 238 shots for one person to have one symptom reduction. Let me say,
the number needed to be but it's like not surprising, right? Because like the thing is that they had so many young people in the trial. If they just had old people, it would have had much lower numbers for number needed to treat.
Right. And all that talk we did before about relative risk reduction wouldn't have applied, because when you've got an issue where the event happening is it's even less. Wait, let's see. It's more than that, but it's when the odds are remote, a relative risk reduction really doesn't change things very much. In other words, if you have a 1 in 1,000 chance of something happening and you double your chances, you still only have a 1 in 500 chance of it happening. You see what I mean? And so it really doesn't help you very much. Honestly, it doesn't. And that's the problem with the people, the TV people saying, wow, this thing's got 95% efficient. Woo. When it really is very misleading.
Yeah, it's against symptomatic infection, right? So let's see some of the numbers, because I think
I'll show them to you in a second. They're good numbers, but let me show them to you because you can always really learn more from the numbers. Then down here at the bottom, I've got myocarditis and pericarditis were identified as serious risks following the administration of the co-morbidities vaccine, and that's written in here verbatim somewhere. And we all know this already, and I've got a lot of data on it. So let me just skip finding it in the small.
So you can see it right here. Post EUA safety surveillance reports received by FDA and CDC identified serious risk for myocarditis and pericarditis following administration. That's what I was talking about. That's the VSD system that identified that.
Great. So they found it too. Actual data confirming my first principles reasoning. Okay. In the second data release, Pfizer says in an August memo, now these dates are really important, I think, because it shows that they knew a lot of this before they started giving advice on whether to have the vaccine or not. It says in an August memo that in the trials, the immunity conferred by the vaccine was equal to that conferred by getting and recovering from wild type SARS-2 infection. And remember, the vaccine always performs better in the trials than it does in the general population for a number of reasons. And that's what I was talking about. But, in their memos and in their memos, they're admitting that the immunity conferred by the vaccine was equal to getting and recovering from the disease, which is not what Dr. Fauci and company were saying.
Well, it's funny if you look at the supplemental appendix or how they analyze the data in the trial.
Yeah. Okay.
And you can see this in the New England Journal report. They had patients that were COVID recovered. They included them in the safety analysis, but excluded them from the efficacy analysis.
Oh, wow. Now that is weird too, to me.
Well, it makes sense if you want to show that the vaccine is very effective, right? So if you include people who are COVID recovered, the marginal benefit of vaccines from this vaccine is small.
Yeah.
And so you're going to include a bunch of people for whom the vaccines doesn't produce any difference between the placebo and the treatment arms.
Or you could even discover other things which are not good though. which they
Yeah,
did
well, they
discover by
did, again, they
accident.
did look at they included them for safety, but not in the analysis of efficacy. And so they were trying, the vaccine
Okay,
trial,
yeah.
it demonstrated efficacy only in the non-COVID recovered. They didn't even
Yeah,
look.
right. Okay. Yeah, the other one, they were equal, so it really didn't demonstrate anything. Is that your
Well,
point? Yeah,
they
I
didn't
can.
analyze it. They didn't report it. They said that's an exclusion in their analysis. They had COVID recovered patients, but they excluded them from the data, the data analysis that resulted in that 95% efficacy number.
Okay. Now this is
Oh, actually, can you go back? I think there's
yes.
one other thing I disagreed with on that trial.
Oh yes.
The short-term side effects, I don't know fully what they knew yet. I mean, this is what like those tens of thousands of pages that are getting released now are
Yeah.
telling us what they knew and didn't know.
Well, okay.
So I mean, I think that's a story that will come out over time about what they knew and didn't know. It's just I don't know that we yet have full visibility on that.
Yeah, the only thing I'm referring to there is that the very first release of information, data, whatever that I looked at had some horrible things on it. Did you see that?
It's of the nature of the VAERS data, right? So the VAERS data.
Well, no, it was the remember that it's the FDA that was trying to hide these things for 55 years, right? Not Pfizer. It was FDA approved it. So they were trying to hide the data so people wouldn't get after them for approving something that was dangerous.
Well, they're required to report all those side effects to VAERS. So those data were not.
There were 9 pages of incredible side effects.
But all of those were reported to VAERS. So it's not that those were hidden like from the public generally. They were reported, like a lot of those were reported to VAERS. It's the same problem. Like how much of it was which was expected versus how much was actually signal. What you really need to do is you need to have those VS. The central problem, Reed, is not this underreporting by Pfizer and so on, or this 50,000 pages or whatever. The central problem here is that the FDA and the CDC have not been transparent with the public about what the VSD and BEST analyses they've done. I mean, most people have never heard of the BEST or the VSD systems, and yet those are the central systems used by the FDA and the CDC in order to identify vaccine side effects.
Real signals, because they know what it should happen in the general population.
And they should be making those analyses public.
But VAERS doesn't even consider that part of it, right?
Yeah, there's no baselines given in VAERS, so it's hard to understand what happened.
It's hard to tell if you've got something or not.
Yeah.
But the guys at the FDA and the CDC should know.
They don't. I mean, I'll tell you, working with the BEST system that I've helped with it's very slow. Those analyses, they take a long time to do. The scientists that work on it tend to be incredibly conservative about calling something a signal until they know they've looked at it from 100 angles.
And that's understandable. I mean, look at the history of breast implants being associated with connective tissue diseases, 25 or 30 years ago. Put DuPont, not DuPont.
DuPont.
Dow Corning.
Oh, Dow Corning, you're right.
Dow Corning, completely out of business. People lost their retirement from it and everything. And it turns out Harvard did a study over 10 years, and there wasn't a correlation between connective tissue diseases and breast implants. And that's why they're back on the market again. Silicone breast implants. So you do have to be conservative and make sure there's really something there before you. So I agree with the conservative.
I mean, the thing is it's the conservatism serves a particular purpose. The question for this vaccine that's being mandated, is that conservatism right? In any case, even leaving aside the conservatism, the question is like transparency. Like
Absolutely. I write about that a lot. In a couple of slides, you'll see what I mean.
And it's killed confidence in not just this vaccine, but in other vaccines too.
I'll tell you, this vaccine and the problems, the public relations problems they had with it, have caused a lot of people to be scared to take any vaccine, which I think is a terrible thing. I mean, you don't want to have your children not take the ones that really are safe and have been proven to be safe, like measles, and are very important, like measles, because this thing was botched. But that is what happened. I mean, it was horrible public relations from this. What I'm saying here, I mean, I don't think this sentence is incorrect. They already knew about the horrible short-term side effects of the vaccine. Certainly they did. Now, I didn't know that the deaths were insignificant, the death difference. And I put that, and certainly that shouldn't be in there, including the deaths in the vaccinated group, including more deaths in the vaccinated group, because you're saying it's insignificant. Then I don't want to put it in.
Well, I mean, I think, but you know, statistical significance is a funny thing, right? So, but the point is that by chance you could have had what would be more versus like it's a really more. What you're saying with statistical significance is it's possible that by chance you just happen to have it more. But look at it from like the point of view just of a regular person, not a statistician. From a regular person's point of view,
scary.
I don't have any evidence that it's going to save my life.
Yeah, the evidence of what they were shooting at. Yeah, there's no evidence, right?
There's no evidence. This trial provides you no evidence that's going to save my life.
Was there any evidence from the trials that there were significant side effects that would be something other than statistically insignificant?
Yeah, so I think the thing about the trial and the side effects, it couldn't find myocarditis, because I think the rates of myocarditis in young people is something on the order of like 1 in, let's say 1 in 5,000 to 1 in 10,000, somewhere in there.
Yeah, right. And they had 18,000 participants. So they really,
so you're not going to find myocarditis differences.
Okay.
You're not going to find the relatively, but the severe, but what you'll find is lots of common side effects. And they're generally like, you know, anaphylaxis after the injection at the injection site, things like that are self-limited.
That's what I'm talking about. You know, nobody died of it, but there were a few people who had to get on an epinephrine drip and stay in the hospital overnight. That's a little scary.
So I mean, I'm not saying it's like, you know, I'm not saying that it's irrelevant. I'm just saying that it's the common side effects that you might expect to find in the trial. It's the uncommon but devastating side effects that are found later. You find that in the post-market surveillance data.
Yeah, because the number of participants goes up when you give it to the general public. That's the main idea, right?
Yeah.
Yeah. So, I mean, and they, of course, now they didn't know anything about long-term side effects. That's part of the.
And we still don't. I mean, we only have. We
still don't. Yeah.
Yeah, because the vaccine's only been out for what, a year and 4 months or something.
Yeah. Just
so, you know, we're going to learn about this over time.
Yeah. So that sentence isn't too bad. It's a little edgy, but.
You know, I've said edgy things myself, I should say. So, by the way, but the bit about the TV doctors, I've been on TV. I've played a TV doctor.
Sorry about that.
No worries, Reed. I mean, the thing is I'm generally saying different things than some of the TV doctors you mentioned.
Oh, I know you. I'm sure you are, but I wish I could have gotten on TV. Maybe I'm too ugly or something. I don't know what it was.
Reed, I tell you what, I traded away. I mean, I had a nice, quiet, happy life before the pandemic.
Oh, I know it. I bet it's been HELL on you in a lot of ways. Yeah. But that's the responsibility of.
Yeah, well, I had no choice, right? I had to.
You had no choice. I mean, it would have been intellectually dishonest for you not to say, "Wait, there's something wrong with the way we're doing this." Yeah.
Yeah.
Which is what I tried to do, but nobody listened to me. Okay, now look at this. I don't want to get into things that are a little bit speculative or maybe too much speculative. And this thing talks about prions and their connection to neurological
I'm not convinced by this. I guess I mean, I'll tell you why. I'm not. It's not that about the biology. Frankly, I don't have the molecular biology background to be able to say one way or the other whether it's plausible or not. I have not seen. Okay, so like this is not prions. This is just the epidemiological data. There was a signal for GBS, you know, Guillain-Barré syndrome.
Yeah. There was in the trials.
No, in the best data or the VSD. I think it's the best data.
Oh yeah, and when you got a lot of people. Oh yeah, sure.
Yeah, but it's very rare. Like one in a million or something, or rarer. So these like sort of neurologic things can happen, but they haven't shown up, right? If this prion thing is going to happen, I think it should have shown up in the best data.
Well, can I, in a couple slides, I'm going to tell you the exact number of neurological complaints over a certain amount of time.
This is VAERS though, right?
Is it VAERS? No, it's not. It's Pfizer data.
Okay.
It's valid. I mean, it's good data as far as I know. So let's get this slide. It's edgy, and a lot of people are talking about this, and it may not be true at all. So let's skip it because it turned white when I moved it down here. I don't know anything about this, but Jay, thanks again, very much for all the time you put into this, and your insight is just so helpful for so many people. I can promise you, it's made a big difference to a lot of people. I wish we weren't getting banned, you know, shadow banned by this. It's a shame, you know, we've worked hard on it, both of us, and we've had problems with it. But thanks again, and let's end on an up note, which is that I think tonight, maybe the 2 sessions we did tonight were our best sessions in a way. You know, we really got down to a lot of the whys and stuff. But let me know when you can do our final session, and I'll look forward to that very much. And also doing the live presentation where we answer people's questions live would be a great thing for people. They have a lot of questions, and I'm sure they will ask us a lot during the presentation. So maybe we can do that in mid-May when I get home.
Yeah, I would love that. It'd be really fun.
It'd be a lot.
I've had a great time talking with you. I've just a really fun time.
Thank you very much. I have
yeah,
to.
I think like Reed, I wish we'd been talking through the whole epidemic. I mean,
I know.
The way that like these kinds of conversations needed to happen, and they needed to happen in public with people who agreed and disagreed with each other. That we would have had a much better policy response if had we done that.
Yeah, I was always hoping I would be chosen to be on a panel to talk about it with the other doctors and whoever convened the panel, but you know, nobody knew who I was. I didn't get anywhere really in sharing my ideas, but they were different. They were different than a lot of other people's ideas, because I do have
we were thinking in aligned ways. I mean, I know we had some disagreements, but for the most part, I think we saw the broad pattern similarly.
Right, and then I have the unusual angle of being able to pepper in a little bit of physics sometimes to make me feel like I'm right for 2 reasons. You know what I mean? Kind of like we talked about, going after it 2 different ways.
Yeah.
And,
well, I think you're the way you think about the biology, the basic biology of it is, I mean, I think it's very productive. It's different than I tend to jump to the epidemiological data, as you can see, to guide my intuition, but
right.
It's really productive. I think these kind of conversations are really productive, and I want to thank you for that.
You're very welcome, and thank you so much. And let's get in touch offline and decide when we're going to do our last one.
Okay. Take care, Reed.
Thank you very much.
Bye now.
Bye-bye. Again, that was Dr. Jay Bhattacharya, an amazing human being and brilliant person. In many, many ways, he's really an exceptional person. So I really hope that you guys have enjoyed this as much as we have. And we'll tune in to parts 4 and 5, which we just finished tonight, and I'll get them up as soon as I can. And then we'll do one more session, which will be the final session, because we're very close to the end now. And then we will start working on our live presentation. So please look out for notices of when that will happen, and have your questions ready. And we will be able to have basically a conversation with you live as you send us questions sometime in May from the campus of Stanford University. So I'll see you then, but don't forget about part 6, which will be coming probably next weekend. We'll take a little break and we'll do the last session next weekend. So thanks again for everything, for making comments, for sharing the videos, and I'll see you soon. Thank you.